Good evening, everyone, and welcome. My name is Jamie Cassels. I'm the President and Vice Chancellor of the University of Victoria, and I want to extend a warm welcome to all of you this evening. It's wonderful to be with you here tonight during IdeaFest for this session on tapping population data, a new era in health research and care. At the University of Victoria, we're in the midst of our IdeaFest week right now. This is the university's 4th annual celebration of knowledge and creativity across our campus. I've had a chance already today to spend time with over 100 undergraduate students displaying the results of their own research earlier on in the morning, and then later in the afternoon, a Café Scientifique put on by the Center on Aging on the art and science of living well, and it was just a tremendous event. So whether this is your first or your second, or for devoted festival goers, your umpteenth event at IdeaFest, I want to thank you for joining us here tonight. It's your participation that makes IdeaFest a real celebration of knowledge and creativity. Our researchers and our research partners are eager to share with you and the wider community their discoveries, their advances, and the results of their learning, and how those things are making a difference in the lives of individuals, a difference in our communities, and a difference across the globe. Tonight's topic is a terrific example of that. Health is a primary concern for all of us at the individual level, at the community level, and across society as a whole. And as you'll hear from the panel, their work is very much embedded in and enabled by the community and by the society in which we do our work, the world beyond the university. So we very much appreciate your engagement with us as we develop, create, and disseminate knowledge that makes our world and our communities a better place. As you'll hear from the panel, our work is usually in collaboration with the community, with institutions, with individuals, with NGOs across society. And tonight is a great example because much of this is in relation to our work, our collaborative work with Island Health. Our goals are aligned to support innovative research, to transfer that research into practice, to improve the health and the quality of life for people living on Vancouver Island. To achieve those goals, we work better together and must work together. Training people, securing resources, sharing expertise, and creating the right environment for research to happen, including population health research. So you'll certainly hear more about the importance of collaboration from our panelists. So now to offer a fuller explanation of tonight's topic, how we're going to proceed, and to introduce our panelists, I want to welcome our moderator, the University of Victoria's Vice President Research, Dr. David Cassel, and thank you again very much for joining us tonight.
Thank you very much, President Cassels. I'd like to also thank everyone for joining us this evening, both members of the Greater Victoria community and our on-campus community. As well, I'd also like to acknowledge the support of two of our IdeaFest sponsors, the Times Colonist and Island Savings. So the title for tonight's event is Tapping Population Data, a New Era in Health Research and Care. I think even to the experts on the panel, this is still a moving target, so we need to talk about this topic. And for those of you who consider yourselves the uninitiated, you're going to learn about all of their insights into this topic and how they perceive the challenge that we have and in healthcare and how we can actually move forward on some of the bigger healthcare challenges that we face by using large-scale population data to answer some pretty fundamental questions in health research and healthcare. Well, so exactly what are we talking about when we're talking about population data? If you've visited a hospital emergency room or a family physician, I'm sure you'd be aware about the vast amount of data that's collected by healthcare systems. These data include everything from patient records to prescriptions to documents for regulatory and compliance processes. Only a generation ago, all these records were in hard copy, and in some places they are still in hard copy. But we are now moving rapidly towards digitization of all of those different types of health records that I just mentioned. Consequently, we are now facing opportunities and challenges presented by the accumulation of all of this information, what some people now call big data. Essentially, big data in healthcare is electronic data, very large sets of electronic data. They're so large and complex and diverse that they are difficult to manage in their own right using traditional management tools and software systems. So we've got a problem there about how to actually collect and maintain these large-scale data sets. But equally, because this data is so interesting, so comprehensive, it presents all sorts of opportunities for its use, but we have interesting challenges ahead of us in terms of thinking about how we actually mine that data in ways that are actually very useful to us. So through the discovery of patterns and trends within the data, researchers can potentially help healthcare professionals to make better and earlier diagnoses. So that's where the research and the clinic actually have a lot to say to one another. And in the process, they'll deliver better treatment and care, with the end result, we hope always to be lowered costs of healthcare and improved quality of life and well-being. So each of our 4 panelists are either managing or utilizing health population data or population health data within their respective fields, and each will address particular challenges and opportunities of this new era. At the conclusion of their presentations, we'll have time for question and discussion, so we'll do the 4 presentations in a row, and then lots of time for Q&A thereafter. I should also inform you that this particular event is being webcast, so if you have any questions, please do speak to our IdeaFest coordinator, Tara Tedesco, who's sitting here in the front row at the end of the evening. So that's the overview of tonight's activities, and what I'd like to do now is to introduce our first speaker, who is Dr. Michael Hayes. Michael is UVic's Director of Health Education and Research and is a professor in the Department of Geography and the School of Public Health and Social Policy. He serves on the Advisory Board for Population Data BC. Michael's research looks at health outcomes in populations and in particular, health inequities, what he terms the social gradients in health outcomes as a result of more or less access to resources. He'll provide us with first an explanation of how population data is a resource for health research in British Columbia. So thanks very much, Michael, and the podium is all yours. Just a second. Okay. Lighting lecture. Okay. There we go.
Oh,
there we go. We have problems with technology all over the place, it seems. Okay, all yours.
Thanks. Somebody break out the popcorn. Listen, thank you very much. It is a great pleasure to be here tonight to be able to talk to you about some of the issues that are facing us around population data, the analysis that we can do with them. And can you hear me now? Thank you, and thanks for the signal. And the ways in which we can actually harness the collective energy of the information, crucially, that we've already invested in to improve health outcomes. I want to just set the scene for the wider conversation that we want to have tonight for just a minute or two. And I want to talk a little bit about the problematic, and then I want to talk a little bit about the opportunities. So the problematic, I see two fundamental problems that face the whole panoply of health research today. The first is health does not equal health care. That was something that was actually coined, a phrase that was coined in a 1974 white paper by Health and Welfare Canada called A New Perspective on the Health of Canadians, so-called Lalonde Report, because Marc Lalonde was the federal minister at the time. Health does not equal health care. Health is mostly shaped by factors outside of the healthcare system, and yet we often conflate the two. Health equals healthcare. When you talk about health, it conjures images of doctors, pharmaceuticals, hospitals, allied professionals, and so forth. It doesn't conjure image of the day-in, day-out quality of everyday life, of the relationships that we develop with people, the quality of our early child experiences, the nature and quality of the work that we do, how we're rewarded for that work, and whether or not we feel valued, whether or not we feel that our participation in a social milieu makes a difference. The quality and nature of our housing, the organization of our communities, and on and on. We are happy somehow, it seems, to live in a society in which 1 in 5 kids can be poor, and then we'll try to fix them later, either through the penal system or through the healthcare system when they suffer premature morbidity and mortality. So that's problem number one. We don't really have a popular discourse that disentangles health from healthcare and thinks about the kinds of investments that we could make to improve health outcomes. The second big problematic that I see concerns that even within the provision of health care, our data systems are organized to pay service providers. They are not organized to give us intelligence about health outcomes. Now you think about how colossally crazy that is. What kind of business venture worth billions of dollars would have data systems that can't even tell what we get for the investment? I think that's kind of a crazy position to be in. We can tell you how many widgets we produce. We can tell you who got paid to do what. We can't tell you if the people who saw those providers did better, did worse, or stayed the same. And that rule of thumb, a third will get better, a third will get worse, and a third will stay the same, doesn't really cut it when we need more nuanced information about what happens to people when they reach out to the healthcare system. Not only in terms of their health outcomes, but crucially, in terms of their experiences with care. Whether or not they felt supported, whether or not they felt honored, engaged, were their voices heard. Also, what about the way that services were organized? Were the organization of services around the individual's needs, or were they around the system's needs? These are important questions for us to be thinking about. I want to now turn to the opportunity. And again, I see two. The first is the emerging partnership that David referred to with Island Health. You know, for too long, university communities, academic settings, and other institutions like health authorities have been silos, have been really finding difficulty to work together because of institutional processes, because of concerns of risk, because of questions about access to patients and data, and so forth. And it blunts what could be a rich opportunity for engagement. What it could be a rich opportunity not only to learn about what we're doing, but to improve upon it. And certainly we would all want that from our systems, wouldn't we? A second major opportunity that is playing out as we speak is something called Support for Patient-Oriented Research, with the unfortunate acronym of SPORE. I don't want to talk about mushrooms. I want to talk about the way in which people can be engaged in the quality of their care, in their own experiences, in the processes of research, and shaping questions that are important to people, because as it turns out, when you ask people what matters to them, that might be very different from what matters to the researcher. And true to the mandate of this university, of which I am so proud to be a member, patient and community engagement is part of what we want to be doing. And so this SPORE initiative, combined with the emerging partnership on island health, provides a fantastic context for us to move forward, not to dwell on the past and lost opportunities that we've had, but to invent the future and to think about the ways in which careful reflection on important questions can lead to, are you ready for it? Improved health outcomes for people that live with us, for ourselves and the people of our community that we care so dearly about. Think about it. Apart from the provincial government, the two largest institutions on the island joining forces to try to help to improve health outcomes and people's experiences of care. I don't know about you, but I think that's a pretty cool mission to be engaged in. So it's against that backdrop that I want to talk about population data, BC, and think about the theme of extracting information value from data sources we've already invested in. So population data, BC, is a multi-institutional, multi-university, nationally active and recognized data and education resource, facilitating training, facilitating research on human health, well-being, and development. And it does so in a variety of ways. So we provide research access to individual level, de-identified, longitudinal data on British Columbia's 4 million residents. We have a data source that actually can take us back 25 years. Now think about it. We've just started a national longitudinal study on aging, where we're going to follow people forward for the next 20 years who are 40 years of age or older to see what health outcomes befall them. But actually, starting today, we've already got 20 years of information we could be looking at and thinking about in that context. We have linkage of data across sectors, not just health, but crucially education, workplaces, early childhood, and so forth, that speak to that broader picture of health outcomes that I alluded to in my opening comments. Secure data storage and archiving services. I know how sensitive health data are. Just think about the tragic events that happened here a short time ago. A breach of ministry data resulting in the loss of employment for people who were dedicated to their work, and sadly, the loss of a life. Needless if we are careful about the way in which we manage our data. A comprehensive education and training service on how best to use these data. Pop Data provides a range of training opportunities, not only for students, but for people working in ministries of health or health authorities, or indeed for researchers who would like to know more about the skills, techniques, and approaches to using these data. It is a partnership. In fact, I'm so proud of the fact that we created a collective based on mutual trust, respect, and a focus on what we were trying to accomplish, which was creating a public utility for the research community of this province and beyond. It's a difficult animal for institutions to get their head around because it breaks down those traditional silos around how things happen. I'm happy to report that the incredible support that we've received from our respective institutions, recruiting, for example, VPs of research or their associates into our governance structure, and working together to think about this. It really, I think, is a fantastically positive signal about the power of a great idea and commitment to keeping the eyes on the prize. We are also supported by multiple funders, including, of course, the Michael Smith Foundation, the province of British Columbia, particularly, but not exclusively, through the Ministry of Health, WorkSafe BC, and others. The SPORE initiative that I mentioned earlier actually has identified Pop Data BC as the core source of data for researchers working in the health sector. And I'm going to conclude with a new day that's going to be, I think, possible as a consequence of choosing this organization for that purpose. There we go. So what kind of data are we talking about? This is where we are today. We have various data sources from the Ministry of Health. You can see, so medical services plan, pharmacare, hospital separations, home and community care, mental health, registry data, and the BC Generations Project, looking at health impacts across multiple generations. We also have population and demographic information. So we have a consolidated MSP file around billing, which gives us information about family economic circumstances, births, stillbirths, marriages, and deaths, so the basic vital statistics, cadastral data. Cadastral data just means data on land plots, so that we can spatialize some of these analyses. And then Citizenship and Immigration Canada has shared with us permanent residence data. Occupational and environmental data from WorkSafe, and of course early child development data through the Early Development Index and the middle years development instrument, and right through to school scores all the way through the school system. So why that's important is this. Just think about the opportunity here. I've been involved in research in which we're trying to see whether or not children's EDI scores at kindergarten and grade 4 are predictive of mental illness in adolescence or young adulthood. Why is that significant? Because if we can actually find out those kids who are likely headed for mental illness problems, we can intervene earlier, not necessarily to prevent mental illness from happening, but certainly to blunt the impress or consequence of when it occurs. And trying to develop strategies to lessen the impact on that for young people. And clearly, mental health issues are huge in young people. Just look at the campus report on mental health and stress across university communities and colleges in Canada. Linkage. The crucial thing here is that what we're able to do is bring these data sources together and get a bigger picture look of what's happening in people's lives. So, it allows us to follow the same individual through various trajectories of service use and so forth. Personal identifiers and mathematical linkage techniques are used to link records belonging to the individuals over time. And I'm going to come to the sensitive issue of how we make sure that privacy is maintained in 1 second. We are authorized to provide this as long as we have permission from the data provider. We don't own these sources, we're only brokering their use. We adhere to the Freedom of Information and Protection and Privacy Act, and we follow the strict guidelines around the data sharing agreements. So linkage is basically about taking two different sources of information about individuals and who they are, and separate from that, information sources about service uses and trajectories. Those two data sources are separated. We use an encrypted crosswalk to mathematically connect using probabilistic linkage the files of service use over here to the individuals in the database over here. Researchers do not ever get information that has personally identifying information attached to the record. All they see are strings of information that relate to service use and trajectories. To be able to get access to these resources, a researcher must be university affiliated, must satisfy peer and ethics review, must satisfy the requirement that the research be in the public interest. We are not interested in helping corporations to make money off publicly held data sources. I just don't think that that's proper. To be in Canada, to obtain relevant consent, to complete a detailed application form, or what's called the data access request form. And then access to the data abstract, in order for that to happen, researchers must also successfully complete privacy training so that there's a sensitivity to why this is important, and of course help in paying the cost of linking these data and making them available for research. We also offer a range of training opportunities. We offer a certificate program with 6 different courses. We put on periodic workshops and so forth. We hold small workshops around sophisticated analytical techniques. My colleague, Dr. Hofer, has offered, for example, longitudinal data analysis workshops with PopData BC and so forth. And we try to make some of these materials available through our website because a part of our mission is to train the next generation of researchers to be smart in the use of these data sources that we have. So I've already mentioned this, that content information and identifiers are held separately. They are held in a locked set of servers that are monitored constantly by video camera. There are 4 people that have access to those servers. Everywhere around is kind of like, so we've got a red zone of very limited access. Then there's a high security zone, which is also monitored and has access for about 17 people who work in the organization. We monitor every keystroke. Access to these data is obtained by a personal key that researchers could, from their laptop, go into a secure data environment and get access to the data that only they are able to see. That is to say, a string of records that they've applied for and have been prepared for them. We have all of the analytical tools that we need for that researcher to perform analyses within the secured fort. So imagine kind of reaching in and doing what you need to do and so forth. Nothing comes out of the fort until it is vetted by our staff. And that vetting is not about what answer did you get. It's about ensuring that cell size are not low enough that there might be an inadvertent identification of an individual. So for example, if you're living in a small town and you have a very rare condition, if we let go that there was one condition in, let's say, Hazleton, we, of course, would inadvertently identify who that person was. So we're very clear about making sure that we have thresholds of cutoff and so forth, because it's in everybody's interest to ensure that privacy is protected. We know that British Columbians want their information to be used for research, but we also know that they're very concerned about privacy and about who gets access under what conditions. I've already mentioned the SRE, so I won't rehearse this slide because I am mindful of the time. I just want to say that all of the data is handled only by those people who are authorized to handle it. Data can only be used for the purposes requested, so people can't go fishing in the data, trying to see what they would come up with and so forth. Confidentiality pledges are required for the research team, and so forth. Moreover, we have had David Flaherty look at, he was a former privacy commissioner. We have audits from Grant Thornton and other firms ensuring that our practices are the highest standard possible in the profession. We need to protect this resource. Now, I just want to finish with this, and I know that you can't see this, but it's a map for me to try to explain where we're going, and I'm going to conclude in about 1 minute. I told you about SPORE. What you see across the top there are where we are today in POP data. Where we want to be tomorrow is here. We want to be able to connect those data to, for example, genetic information and epigenetic information, biobanks and so forth, so that we can know more about the biological processes that are happening to people experiencing these various things. We won't know who they are, but we'll know how those processes play out, and that's information we can use in the future to make better decisions and provide better services. Geospatial data, additional administrative data, clinical data, researcher collected data. If you've got a large cohort of people, the possibility of bringing that in. We might be able to partner with Island Health and think about some of the electronic health records that you're going to hear about from Ken and the ways in which we could marshal those to have better information, make better decisions about what we're doing. In terms of the users, right now it's researchers. Why shouldn't it be people from health authorities? Why shouldn't it be clinicians? Maybe the public, if we're moving toward questions about patient-oriented research. What's the harm in helping people to understand this? Maybe we all benefit from greater information. In terms of access, right now everything is about a hypothesis. You have to be able to specify what your question is and run a hypothesis. But maybe in the future we could think about just data mining, about trying to generate hypotheses or think about potential hypotheses by looking at this rich source of data that we have. And finally, training and KT. The possibility of one-on-one method support, formal training programs, and so forth. And when I think about governance, right now, we are a research-based community. But in the future, we need to invite people from the health authorities, from the public, from various other sectors of our society, so that there's a table of transparency so people can be confident that we are asking questions in the public interest while protecting people's privacy and security of their information, balancing that tension. Thank you so much for listening to me. Thank you.
Thanks so much, Michael. So, onward. Very pleased to introduce our second speaker, Dr. Kenneth Moselle. Ken is the Island Health Authority's information architect and is also an adjunct professor in the Department of Psychology at UVic. As the title information architect implies, he is an established leader in the design of solutions for structuring the flow of information among diverse data sources and data users to provide the support that they need so that they can actually carry on their mission of delivering healthcare, quality healthcare. So he is currently the lead researcher for Island Health's major electronic health record initiative. His work involves developing procedures for the launch of a secure research environment within Island Health. So his presentation will focus in part on that secure research environment and what he believes can be achieved with the health authorities' warehouse data through a partnership with the research community, including with UVic Center on Aging. So thanks so much for being with us tonight, Ken, and I'll invite you over here. We're close. You don't want to give...
I suppose you could say I'm marching to the beat of a different drum, or I'm shifting from landscape to portrait. Okay.
Please adjust the microphone to, I have very good hearing, but the hearing is not very well tuned to this acoustically good auditorium.
Okay.
Most of the voices without the mic, but the mic would be good.
How am I doing?
That's a little better.
Okay, if you can't hear me, gesticulate wildly. All right, now my wife told me, she says, now remember, you're supposed to entertain people. True confession, I was going to entitle this presentation Nerd of the Rings for reasons that will become abundantly obvious. Just so that I'm clear, I'm speaking purely of myself, and I think that will also become perfectly obvious. So, okay. So I was going to start, and I guess I should also, up front, some apologies for applying a sharp rhetorical edge to the material at hand, but the devil made me do it. Anyway, I was going to start with an entertaining questionnaire intended to produce a heightened state of cortical activation while insidiously lulling you into a false sense of security. But in the spirit of informed consent, or at least notification, I will start with a bald-faced assertion. A research partnership that is not anchored in a target information architecture or blueprint, if you wish, at best will enable a loose amalgamation of knowledge generation activities that will never coalesce into a functionally integrated body of knowledge that will effectively support or drive the quality health service agenda at a population level. Okay? So let's jump in. Our journey tonight starts with very large quantities of granular person-level data in the EHR. We will then work our way up to the level of service system quality surveillance at a population level. Then for the return trip, transporting our analytical products and associated plans and change initiatives back down into the clinical decision support tools in the electronic health record. So that's the target information architecture there. It represents a complex analytical agenda that entails constructing and piecing together a large number of analytically derived entities. As such, the work cries out for a blueprint, which in the world of information architecture, we refer to as an information architecture. And if it doesn't exist yet, we call it a target information architecture. And if, as my informed consent questionnaire implies, that architecture is never going to be realized without researchers interacting with the health authorities' data, and I'm not just saying that to be friendly, it is a target information architecture for a research partnership involving the health authority, the research community, and technology development partners to build the absolutely critical technical infrastructure enablers, e.g. the electronic health record or EHR. So let's jump in. The journey starts down here in the bottom right. I'm going to beat the living daylights out of this diagram. Starts down here in the bottom right with granular person-level data. Some more person-level data from clients, unfiltered by the clinicians, Dr. Hofer. Up to aggregate level information, i.e. portions of the population in care. I need a page turner. Then up to the population level of analysis, which we will soon delve into in far greater detail. and then cascading the products of the analytics back down to the point of service. I think we call that knowledge translation, or KT. And I would note, pay careful attention to that arrow shooting out over to the right. We're also talking about rolling the information out across the jurisdictional divide. Since healthcare may only have control over 20% of the variance in health-related outcomes, but it has almost a monopoly on information about the health-related impacts of services both inside the health service system and outside the health service system, so it has an obligation to make that information available. Well and good, but the term architecture implies structure. So what is the structure in this diagram? What is it trying to say to you? Well, there's some structure. You'll note 3 colored vertical bands. Band on the right describes the range of functions performed by the health service system. The band on the left describes the information entities that support or enable the execution of those functions. And the band in the middle describes the information technologies that support the flow of information from the point of service on the right to the researchers on the left, and then back again to the service functions on the right. It's a loop. That's the vertical structure. Then there's the horizontal layering to the functions performed by the service system, with the point of service positioned on the foundation, management of operations in the middle, management's always in the middle, and population planning and service system optimization functions layered on top. Each of these layers works with its own information entities and leverages off the distinctive technology enablers in that middle vertical band. Now, get ready. Now is that last diagram in effect describes the health service system as a hierarchically arrayed set of regulatory mechanisms, with each layer exercising some degree of influence or control over the layers below. This kind of hierarchical arrangement of information-dependent functions, that sounds like a nerd, doesn't it? Yeah, can actually work, but success is not guaranteed. It is dependent on the extent to which the system observes the most fundamental law governing the behavior and dynamics of any information-dependent open system. And I'm speaking of Ashby's law of requisite variety. It basically says if system A is regulating system B, then system A must know what system B knows. If system A cannot get its head wrapped around the level of detail that is contained in system B, then system A must be working from models that accurately reflect the cause-effect relationships that determine the behavior of the system being regulated, namely system B. Conant, 1970, calls this the good regulator theorem. If you break the law, consequences include nothing. The system does nothing, does not change despite efforts to get it to change, or surprises, possibly unwelcome, or inaccurate understandings of how well change efforts are working or what is actually causing the changes. And now we come to my favorite, pathological inertia, which can take 2 forms: doing nothing when there is good reason to do something, or doing something when there is no good reason for doing so. Bottom line, failure to respond adaptively to pressures bearing down on the system, e.g. from the populations receiving care, and inefficient use of resources. In other words, effectiveness takes a hit, and so does sustainability. So don't break the law. Anyway, into the details now. Let's focus on the yellow column to the right. At the foundation, we have clinicians interacting with patients or clients via the intermediary of the electronic health record. We also have clients or patients injecting information directly into the health service system via the intermediary of consumer-facing portals. And we have documentation of activities and use of health resources, which enables us to track expenditures and cost out our services, which is kind of important. We move up to the level of operational management of services. Here, we are concerned with those feedback mechanisms that function to maintain homeostasis in an open system, e.g. health service system that is exposed to demand from the population at risk or in need of service and needs to keep the show going. At this level, we also have those capacity management functions that set service levels in keeping with funding and availability of people to do the work. Then we move up to the next level. Unlike operational management, which is intended to keep the system in the groove, at the next level up, we're talking about those functions that are intended to get the system out of the groove or change the mechanisms that keep it in the groove. We start with a surveillance layer, but I'm not speaking here about tracking outbreaks of illness. I am speaking about tracking quality. the extent to which best possible outcomes are achieved for populations at risk, and tracking outbreaks or shortfalls in theoretically achievable quality. And then the final leap, strategic planning on the basis of operations research type models that enable strategies to be pre-validated through scenario testing within the models. Now, FYI, if you're a clinical neuropsychologist or a cognitive psychologist, you would realize that what I have described is the functional intelligence of the health service system, but this discussion is probably best left for another time. And I won't talk about the image of gangsters in that picture there either. Okay, so that's the column on the right, the health service system depicted as a hierarchically arrayed set of information-based regulatory mechanisms. Moving right along, let us now focus on the middle portion. Here we look at the technology enablers for all of those information-dependent functions. We'll start with the technology enablers for the point of service delivery of care, the electronic health record, where all of the base granular information about need, risk, interventions, and outcomes is getting deposited by clinicians. It is also bringing in information from machines, e.g. proteomic or genetic data from mass spectrometers. And at that level, we also have the portal and associated web apps, including health promotion apps. Take note, the EHR is also home of real-time clinical decision support. Let that be emblazoned in your psyches, which embodies the results of clinical analytics concerned with best practice. So the EHR is absolutely critical to the strategy for translating knowledge back to practice. It's the last mile in the KT chain. And now, into the data warehouse. The information in the EHR is deposited in a scary place where ordinary humans never visit, called the desolation of smog, also known as the clinical events table, which does not get along well with analytical tools like SAS or SPSS. So the information from the EHR and other source systems must be extracted and built into the data warehouse in a form that can be queried directly by tools like SAS or SPSS or R. R, yes. And then, finally, that arrow up there on the right again. We need this warehouse to be able to interact with other secure research environments or data holdings like Population Data BC, because the health authority may have whacks of granular person-level health data, but they don't have all the pertinent data by any means. So there you have the hierarchically arrayed service system functions interacting with information enablers. We're not done. We shift our attention over to the column on the left, where the researchers and statisticians enter into the picture in a critical way. They have a ton of work to do. At a foundation level, I'll mention two key activities. One, abstracting and validating best practices. Yes, abstracting and validating best practices from data concerned with interventions and associated health-related outcomes, with these analytical products then getting coded back into the EHR as clinical decision support rules. And two, using data from the EHR and from patient portals to generate meaningful measures of trajectories and changes in trajectories for people who have chronic conditions. Ordinary humans cannot wield the statistical tools necessary to do this sort of thing, but we have people right here in the room tonight who have the skills. And in support of operational management and strategic planning, we're also talking about generating models that answer questions like, what does it cost to increase the likelihood of a best possible outcome within a given cohort? Not a simple question. And an even more interesting question, what are the direct and indirect costs associated with failure to do all those good and right things? Once we can measure health-related outcomes and estimate the portion of the variance associated with the provision of health services, then we are in a position to generate more robust estimates of the contribution of non-medical factors to population health disparities. And we can generate models of the system as a whole and optimize those models against specific targets, e.g. quality for populations at risk, or we can even aspire to optimize the models conjointly on the basis of effectiveness and cost, i.e. sustainable quality. Anyway, that's the vision. Now, this may all sound pretty easy, and we can all just tackle one piece of this whole structure in an ad hoc and disconnected manner, and we'll all come together. But I don't think so. And here's the issue. Information in this model is flowing up from the point of service to the population level via information technology enablers and is flowing back down through those enablers. Now, in my world, flow implies sequence, and sequence implies dependencies and pieces working together. We can see those dependencies highlighted in this diagram. I won't go into details. What it's saying basically is that each layer builds on the analytic products and associated service system activities from the layers below. And because, any statisticians in the room? Because statistical error accumulates nonlinearly as we combine lower order analytical entities into more fully integrated analytical products, those analytical entities must be statistically robust and well validated. Otherwise, the whole thing just crumbles. Now, my focus tonight is on architecture, not privacy, but I would note that there are some important analytics involved in disclosing data to researchers. I'm speaking specifically of the analysis of risk for re-identification associated with nominally de-identified bodies of information, and that's a pretty arcane science in and of itself. I'm not going to go into it now. Assuming you have mastery of such data de-identification tools and you have appropriate security controls wrapped around your data to prevent unauthorized access, then it is possible to stage a secure research environment that enables researchers to access warehoused health data and do their part in the construction of the target information architecture. Now, this slide provides a bit more detail on how this task is being approached in Island Health, and I can go into great length about this at some other time. So, in summary, what do we need to carry out this research and development building plan? Answer, everything I just said in the sequence implied by the diagram. And I would note in for a data penny, in for a data pound. Once we start to use our warehouse data to develop notions of best practice, then we are obligated to develop notions of best practice that are then propagated back to the point of service when our data is touching patient care or client care. We are obligated to carry out further analysis to validate that our brilliant ideas are actually working or to show that they are still working. We have to do that. So in summary, I would know for everybody's benefit, we're talking about 7 service system functions, 7 supported technical infrastructure, architectural designs and builds, and 7 analytical foundations. These pieces need to be fashioned out of large quantities of quality, messy, raw data and transformed into load-bearing, industrial-grade analytical building blocks. And the pieces have to fit together tightly and consistently across the architecture. So, I would argue, given the complexity of the undertaking, the strong dependencies that relate one layer to another, the necessities to build in a particular sequence, and the coordination that must take place among all of the involved parties, this model is never going to happen, and it will not be there to drive the quality sustainability agenda in healthcare unless all of the involved parties can agree that we all work together and navigate the research and knowledge translation agenda toward an explicitly articulated target information architecture. So this is not just a research, I'm not talking about a research partnership, it's a research and development partnership organized around a planned set of information deliverables that are key to the functions performed in a layered health service system. That's all I have to say about this tonight. Thank you for listening.
Thanks, Ken. That seemed pretty straightforward. At least until you got to the part about the humans coordinating, and then you lost me. But fortunately, our next speaker is a psychologist, so maybe he'll have some insights about that. So, third speaker tonight is Dr. Scott Hofer. Scott is the director of UVic Center on Aging and a professor, thank goodness, as I say, in the Department of Psychology. His research focuses on individual differences in developmental and aging-related processes and involves analysis of existing longitudinal studies and data collection using intensive measurement designs. He's particularly interested in understanding the factors associated with the early detection of cognitive changes associated with dementia and other health-related causes. So along these lines, he and his colleagues are collaborating with Island Health and clinicians to bring the assessment of neurocognitive and patient-reported outcomes into the home and clinic to enable earlier diagnosis and improve care. So Scott tonight will describe his efforts to capture change data within these clinical and home settings and the benefits of linking it to population health data. So thanks very much, Scott.
Thanks so much. Ken, you definitely need more than 2 dimensions next time. What I'd like to talk about today is the importance of measuring people more often to detect within-person changes, within-person variation. Important not only for diagnoses or evaluation, but for really basic longitudinal research. So I'd like to go over some of the kind of work that I've done and how this all links back into the opportunities we have right here, right now, for linkage with population health data and where this is going to get us. Much of my work has been in lifespan development, life course epidemiology, depending on who I work with or who I'm talking with. It's about the investigation of these long-term causes on chronic disease risk, dementia, as well as just general changes related to physical and cognitive capabilities. We look at things that happen early in childhood and adolescence and in young adulthood, middle adulthood, and how all these things play out and build up over time to lead to greater or lesser risk in adulthood, often later adulthood. We necessarily focus on very long periods of the lifespan. Some of the studies I work with have followed the same individuals for over 70 years. Those are relatively rare studies. Most studies begin in late middle age or after age 65 and then follow people up from there. We're very interested in the interactions among biological, behavioral, psychosocial pathways. Most of these longitudinal studies incorporate all of these types of variables. So often very, very rich data sets that we can follow up and understand how changes and variation related to a variety of risk factors relate to changes in biological and behavioral outcomes. We're often interested in a comparison across studies that differ in birth cohort, different population, country. And one important question throughout is the modifiability of risk factors. And when these risk factors, if we could intervene, when would be the most important time to intervene? And often we find that's in very early life. So my current research activity, I'm director of the Integrative Analysis of Longitudinal Studies of Aging, which is comprised now of 99 longitudinal studies. I need one more, please. This is a very collegial, collaborative network of researchers and research teams from all over the world associated with many of these long-term longitudinal studies, focused on aging, and many of them now focused on dementia outcomes. We also, my lab is involved in a number of intensive measurement designs, and I'll tell you a bit more about that. Since I've been here, I've been collaborating with a number of wonderful colleagues, Ken and others at Island Health, about including patient-reported outcomes in clinical practice and why that might be important. I'll tell you a little bit about that and the importance of understanding these dynamics to maybe give better diagnostic information and information about evaluation that could actually change practice. And one very exciting opportunity here, and you've heard this from the 2 previous speakers, is the opportunity to link this kind of longitudinal data, new data that we're bringing, to existing health data. And the opportunities there are just incredible, and I'll talk about that at the very end. So from my view, integrating practice and science just makes a lot of sense. Everyone wins. From basic science, we're going to learn a great deal more about changes in health, in cognitive and physical capabilities, in well-being, and what impacts these changes. I think that's the most important thing. This is basic science. This is what we're trying to do with life course epidemiology or lifespan developmental psychology. In clinical practice, by bringing more and better measurements, we're able to actually improve diagnostics. And from a within-person perspective, that means detecting it when an individual is changing from the level of functioning that they were at just previously, or maybe over the last few years. This also permits us to evaluate treatment outcomes, change from prior status. So we actually need to have measurements that occurred before whatever treatment or whatever event happened to understand the impact of that event or of that treatment protocol. and the opportunity also for post-discharge surveillance, so being able to follow up an individual and ensuring that their health is maintained, that anything that needs to be cared for can be detected very quickly. So we're looking at that as well. So that's the kind of surveillance or monitoring that might occur if we include additional measurements. In terms of patients, I think this is the most exciting and important part, and you're all aware now of all the technology we have with Fitbit and tracking our activity and tracking our sleep and all these individual metrics. Well, that's all kind of part of it, but it's really making use of that data in new ways that my colleagues are working on. So really understanding what the impact of lifestyle changes, of your physical activity, of health behaviors generally, how that actually impacts you, impacts your well-being, shows your progression. We're not really seeing a lot of work on how these things are interrelated, and that's what another area we're doing, and I think that makes a lot of sense within healthcare as well. So improving longitudinal measurements, in a large part, it's all about the design. We need to measure people more often. The key here is patient reports are just essential to understand the kinds of changes that are occurring within a person that are important. And these are often the more subjective things that we can't get access to through any objective means, through any biomarker or lab assay or any technology development. These are still reports that need to come from each of you. Patient-reported outcomes are defined as patient self-reports about their health or circumstances surrounding their health. That means it can be many, many different things. They're often very much related to the kinds of measurements that are included in these long-term longitudinal studies that we work with. They've been adapted for this kind of purpose. Now, they've been reported to have all kinds of bias, distortion, and error, but we find that that's really only occurs when you measure them once. When you begin to measure a person more frequently, you begin to understand that the rating relative to themselves is a very accurate and useful assessment. But doing that, measuring people more often, we've got to kick it out to outside of the lab, outside of the clinic, where it just takes too much time and the travel time and everything else. We've got to move it into a person's everyday life. And so we are seeing a lot of things pushed out to mobile technology, to home-based assessment, and this seems to be working very, very well. So a patient-reported outcome, it's a questionnaire used in a clinical setting. It can measure a variety of symptoms, functioning, well-being, quality of life, perceptions, a whole variety of things are now being developed and used. PROMISE is a program that was funded by NIH to actually develop the psychometrics, develop better measurements around particular domains, so physical function, pain intensity, fatigue, sleep disturbance. These are all well-established scales, and what they've attempted to do here was standardize them and make them more psychometrically sound. These are all available for use. My colleague Ken describes another variety of assessments that we tend to use as patient-demonstrated outcomes, and I like this very much. This has to do more with cognitive functioning, so you're giving them a test, and they're having to perform this under SPEEDed or other conditions, and these are increasingly available for home or clinic or mobile assessment. And this is a very exciting area of development because this allows us to measure, again, people more frequently and without as much burden on their time and their effort. So this is something that's very useful. We're seeing some old standards like CANTAB come out and be used in these mobile devices. So my main point here is that embedding these kinds of measurements, these more frequent assessments, is very important for both longitudinal research, basic research, as well as improving healthcare. It allows us to focus on within-person process. It enables measurement of these dynamic phenotypes. So stress reactivity is something that people are very interested in, that people differ in terms of their reaction to what might be the same objective stressor. So that reactivity becomes an important dynamic phenotype, which is only measurable if you measure both stress and frequency of stress as well as well-being or your affect on those occasions. So it requires multivariate assessments to get at these new measurements that could have real clinical application. A major focus here is on detection of accelerated within-person change. Individual differences are broad from early life on. We always see that we all differ from one another in quite a lot of ways. An individual change point is the idea that you're going to be differing from yourself, from where you were previously. And this is a very important idea to separate out these between-person differences from these within-person changes. So the diagnosis moves to a change from where you were. So one area that I'm interested in is in these kinds of changes that occur related to dementia. And we know this from existing longitudinal studies where when we have a clinical diagnosis, we're able to now go back and observe how the individual was changing prior to that point of diagnosis. So where they met this basically a threshold, a line in the sand that you've met this threshold for dementia. But what we see then is that on more sensitive tests of cognition, of processing speed, of reasoning, of memory, that these changes are actually occurring, this acceleration in change is occurring up to 10 or 12 years prior to that diagnosis. So we know that this is a slowly progressive disease, and it points that we may be able to actually detect this a lot earlier. Now the problem here is that we have no cure, we have no intervention. I think the last drug trial that was approved was in 2003, so we're still very, very much on the discovery phase of the kinds of progression and dementia outcomes. But still there are a number of good reasons for why this might be useful, and certainly when we identify the biological pathway, we identify a potential treatment, we're going to want to identify individuals in the early phase of the disease who might most benefit. So again, it's this idea that early detection means potentially better and earlier intervention. Just the challenge here of detecting these changes, it's this preclinical phase where there's this beginning to be an accelerated change from what might be expected with just normal aging or for other reasons. And that's really challenging because that change point is going to be a very sensitive indicator. So the more frequent assessments are required. And as I mentioned, the individual differences are quite broad. And the problem with a threshold model for detecting dementia is that people begin at different levels. And this is the idea of cognitive reserve. This idea that individuals with higher intelligence early in life, with higher education, which we've shown to have causal benefit for improving adult intelligence, but as well socioeconomic status and how cognitively engaged a person is, all are good markers of this idea of reserve. And what happens here is that we're detecting people with higher levels of reserve at a much later phase of the disease. So they're at a much faster progression then. So we'd be missing individuals, or we'd be detecting the progression of the disease much later in individuals who began at a higher level. That's basically the idea. From a within-person diagnosis perspective, we'd be able to detect everyone at about the same when they were changing from themselves. So that's the whole idea of a within-person approach. Different peoples have different normative levels of performance, and the big question here is this individual changing more rapidly than they have in the past, in their prior level? That's the basic idea. The problem is it takes a lot more measurement. It takes a lot more time, and the longitudinal studies require a great deal more effort. The most typical longitudinal studies are spaced every maybe 2, 3, or 4 years. So we see someone perhaps for a 2-hour or maybe an 8-hour, and some studies it's a 2-day test battery, a very intensive workup. And then we don't see that individual again for maybe 3 years later. And that's what we learn about them again, this 2-hour, 2-day assessment. And this is spaced regularly, and so this is what goes into these hundreds of studies, 199 studies with IELTS. Very few studies measure more frequently every year. What we're talking about now is measuring people more frequently across maybe 7 days or 14 days, and then do this in these intermittent bursts of measurement to give us this idea, a better idea of the dynamics, a better idea of the kinds of changes that are occurring from time to time, to get at these dynamic phenotypes. And every time we look, we see a great deal of intra-individual variability. This is a study that we did with community participants. This was a study of really trying to learn how to better measure well-being. There's a lot of different scales of well-being out there, so we used them all. And we asked people to fill out an end-of-day daily diary on 14 days. And just what you see here, I just wanted you to get an idea of what's going on. Every line is an individual, and what you see is a lot of variation from day to day. We see that all the time. Anytime we measure a person more frequently, we see that they vary from themselves quite a bit on most scales. This is on well-being. Amanda Kelly, and in working with Eric Shafansky and Al Hayashi and Christine Hall at Island Health and a number of other colleagues in our lab, embedded some patient-reported outcomes within a clinical practice. And this was a daily survey for over 7 days. And a variety of things were measured. We included the short form 36, a very standard measure of health limitations. And again, we saw that kind of day-to-day variability in energy and vitality and pain, in self-rated health, so that a person across days is just changing for various reasons. These changes in health limitations, in physical functioning, in energy, in social functioning, are all related to well-being. So your overall rate of positive affect or negative affect. And this just shows you that what we get from day to day, so physical activity is one of the most consistent predictors of well-being and of cognition. The more active you are on a particular day, often the better you'll feel at the end of the day. So you'll rate yourself as having greater positive affect. And so this is one of the most consistent things we find in our studies of college students and older adults and everyone. So these are the kinds of dynamics we get when we do these daily diary studies. Just to kind of wrap up here, one thing that's been really interesting for me to see is that the kinds of findings we get from these long-term longitudinal studies, that really, where we're really talking about long-term changes and how change is related, we certainly do find this effect of being more physically active is related to your cognitive functioning and to your well-being over time. So that a person who is more physically active, they tend to maintain their abilities longer, their physical and cognitive abilities longer. But what's interesting is when we measure people more frequently, we find that the same relation applies, that on days that a person is more physically active, they also report higher well-being. In one study at Syracuse with a colleague of mine, we found that their cognition was better. So these things change from day to day, and they're affected by what we do day to day. And it's this kind of thinking, it's this kind of work that we think would be really impactful for obtaining better diagnoses, of understanding the kinds of things that are important to individuals about maintaining their health and their quality of life and well-being. But also very important for improving our measurements and improving our opportunity to detect change much, much earlier. So what we're talking about is this inverse perfect storm. We really do have all the components now. What's happening here is the most exciting thing I've ever been part of in my life. All the components with Island Health and Cerner and all the great colleagues here at UVic and UBC to make something big happen. And embedding this kind of long-term semi-continuous. You don't want to measure a person all the time, every day, but to do it in a smart way, to bring that structured data collection in, I think is one of the most important things we can do. And embedding that within a healthcare system, within health data, within population data, just really permits us to link up what's going on in individual lives and the kinds of things that the kinds of risk and protective factors that matter, to link this into how we can improve health and understand health and health care better. So, and making this data useful to participants and caregivers is a key aim. All of these components need to come together, and I really do think they can. Thank you very much.
Dr. Neena Chappell is our final presenter. Neena holds a Canada Research Chair in Social Gerontology and is a professor in the Department of Sociology, and is also in the Center of Aging, of which she was also the first director. A leader in gerontological research, she focuses on issues around aging, including caregiving, social support, healthy aging, and dementia care. Her research is also characterized by its engagement with the community. She is currently leading the Caregiver Appraisal Study funded by the Alzheimer Drug Therapy Initiative to discover the benefits and limitations of medications from a unique perspective, that of the caregiver. Her presentation will look at the potential of population data to improve medication use and coverage. So thanks very much, Neena.
Thank you. Thank you, David. I hope you're ready to hear about a specific study that uses both primary data collected from individuals and population data. It's within the area of medications for Alzheimer's and other dementias. It's in the area of medication use. Prescription drugs are the third largest category of health spending in Canada, estimated at about 14%. In 2013, $34.5 billion was spent on drugs. 85% of that was spent on prescription drugs. From 2001 to 2013, the fastest growing category of health system spending was in fact on prescription drugs. So there was a lot of attention by governments given to this area and about how to cope with the ever increasing costs of prescription drugs. These data, by the way, are all taken from a recent report of the Canadian Institutes of Health Information. It's available online if you want to Google it. Since 2005, spending has been slowing, and as of a couple of years ago, the increase, it's still increasing, but the increase on the amount that we spend on prescription drugs is no longer the fastest growing within the healthcare system. Over the last couple of years, the increase in spending on hospital and physician services has surpassed it. In 2013, just over 40% of spending on prescription drugs was financed by the public health sector, 35% by private insurers, and just under a quarter out of pocket. Generic drugs accounted for just under 40% of public drug program spending. There are, of course, with prescription drugs, many non-cost concerns, although cost concerns often seem to be uppermost in the minds of government, certainly not always. Adverse side effects, unknown long-term effects of drugs, and what we call disease creep, that there seem to be more and more new diseases appearing for which we are offered more and more prescription drugs. In this area of prescription drug use, there are a number of initiatives, and I only have time to mention a couple of them very quickly because I want to get on to the particular study we've been conducting. The Drug Safety and Effectiveness Network, DSEN, is a national program run out of CIHR in Ottawa. It has regional centers or nodes across the country. It is directed by a broadly based advisory group for real world or what we call post-market research. So if, for example, there are a number of adverse drug reactions for a particular drug that seem to be appearing in Ontario, DSEN has established these centers so they can very quickly go to each of their regional centers and say, run your population databases and tell us if people on that particular drug in your province or region, in BC is a region, are appearing at emergency wards more often, if they're having more surgeries, if they're being diagnosed with particular illnesses. It's known as the Pharmacoepidemiology Group, which is part of the Therapeutics Initiative, which I'll mention in a bit more about in a minute, is our BC region Deason Center, and I'll give you a specific example in a minute about that. Others have gone through some of the types of data sets that we have available to us when we talk about POP data, so I won't do that. So the Alzheimer Drug Therapy Initiative, which it's okay, David, that you got it wrong, because people have a really tough time understanding it. It actually consists of 5 separate studies, 4 of which run out of UVic. I'm the overall lead on them, and I don't actually particularly want to talk about the caregiver study today, because I think the more interesting studies that are linked more essentially to the large population data sets are in fact the other studies. The Alzheimer Drug Therapy Initiative was actually initiated in 2007, and it was not slated to go on this long. In fact, Rachel Scarth here at the university keeps telling me this is formally called a pilot. It's the longest running pilot she's seen. We were caught up with the drug firings in the Ministry of Health for data breaches, and I'm quick to note that 4 of the 5 people who were fired have either been reinstated or otherwise public statements made that they should not have been fired. But while that was happening, drug studies in the province that had access to population data were halted from working on those data. We're now back working on those data within this study. It was initiated because cholinesterase inhibitors for dementias, there are 3 of them. The one that you'll be most familiar with is Aricept, because it was the first on the market, and for a long time it was the only one. It was easiest to take. You only needed 1 pill a day. The others needed more, although they've subsequently came out with versions where you also only need it 1 a day, and Exelon has a patch. Because all of the other provinces in Canada provided the coverage for these drugs under their provincial health programs. BC didn't. The Therapeutics Initiative, which I mentioned a couple of minutes ago, was for a long time the body which for the provincial government reviewed scientific evidence and gave recommendations on whether or not drugs should be covered. And it was based very much on effectiveness, not necessarily the lowest price drug. That organization still exists, but their funding's been grossly cut, and a council now makes decisions on drugs that are covered, and that council does allow representatives from the drug manufacturers on its body. But while the Therapeutics Initiative was performing that function on 3 different occasions, they recommended against covering cholinesterase inhibitors because they argued the scientific evidence did not warrant it. So the former Liberal government set up the ADTI, which is a real-world experiment where these drugs would be covered for a specified period of time. They're being covered longer. They're still being covered because of the delay in the study. And researchers would study effectiveness so they could get a decision on whether or not to cover these drugs. So this is a study where you see a collaboration between the provincial government, researchers in the provincial government, researchers at the University of Victoria, and researchers at UBC. And the 4 studies that are being conducted out of UVic are the ones that you see before you. And let me briefly sort of explain what they will do, because I think it'll give you a very concrete example of how this population level data can be used. The cost and utilization study can, through provincial health records, so it's health records, it's hospital records, it's PharmaNet records, They can look at everyone who's received these particular drugs for dementia in the province, and they can compare their usage of other services with others who have received the drug but are not covered through this program, as well as with those who have the similar or same diagnosis of dementia and are not receiving this drug, okay? And they can compute the services that those three groups are using. They can look at it before and after the program was initiated, and they can see whether or not these drugs are saving the government any money if, for example, these people with dementia who are on these drugs now end up at emergency less often or in the hospital less often, or there is a delay in institutionalization. The existing research that does show a delay in institutionalization, and not all of it does, it's very minor. It's often a few days, maybe a month is the delay. And that's all using these government databases that are in existence, and that we're analyzing this data as I speak, literally as I speak, because sometimes we have to put through a multivariate run, and we have to literally wait overnight in order to get the results out of it because the databases are so large. There are over 15,000 British Columbians who are on cholinesterase inhibitors and are covered. There's a bit higher number who are on these drugs and are not covered, and then there's another I think it's around 20,000 who have the same diagnosis but are not on these drugs. So they're very large databases. The clinical epidemiology study takes data from what's known as a special authority form, which physicians fill out in order for patients to get coverage within the program, okay? And it has clinical information on it about the individual's cognition, also about their physical functioning in terms of activities of daily living and instrumental activities of daily living, and also various behaviors, aggression, and so on and so forth. And those data are then linked to these larger databases on service utilization. In this instance, they're also linked to what we call home and community care data, so we can also see the usage of home support and home care data, which the cost and utilization study does not utilize. The cost and utilization study is headed by a researcher by the name of Colin Dormuth from UBC, who heads up the PEG group, which I mentioned earlier. So what we're doing is we're looking at trajectories of drug use and also effectiveness, because clinicians reassess, best practice guidelines, they don't always do it, but best practice guidelines say they should be assessing individuals on these drugs every 6 months. And in order to get a renewal for their coverage, they have to fill out these forms that have the cognition data on it. So we can follow effectiveness. There's, three, it depends. Some of the measures have various subscales in them. But anyway, there are a number of measures of cognition. So we can track those individuals for 2 years, every 6 months, to see if they're holding their own in terms of cognitive ability, or if they're deteriorating, or if they're increasing. And we can link that with the larger data sets to whether or not there are differences, for example, in which drug is prescribed, whether or not those drugs are discontinued, whether or not they're switched drugs, by whether it's a specialist physician prescribing the drugs or a GP, if it's in an urban center or a rural center, depending on past history of illnesses. All of that information comes from these larger data sets. The seniors medication study is a much smaller study with only 300 individuals in it, where we collect what we call primary data, so it's interview data from the physician, from the patient with dementia, and from the primary family caregiver, all about the illness and the manifestation of the illness. And that information is linked to also to this utilization data, the larger health data. It is also linked to the caregiver appraisal study, because the caregiver appraisal study, every caregiver in the seniors medication study is also a caregiver in the caregiver appraisal study. The caregiver appraisal study is province-wide. It has just under 1,000 individuals in it, and they're all primary caregivers to individuals with dementia who have coverage and are taking these cholinesterase inhibitors. Caregivers are seldom studied in any studies of these drugs. One of the main purposes of that study, we interviewed caregivers face-to-face for an hour and a half at 6 months, when the family member was taking the drug for 6 months, because that's when physicians are supposed to make their decision as to whether or not the individual continues on the drug. And we have assessments from the family caregivers who see these people pretty well 24/7 to compare with the assessments that the physicians have made. And we have permission from the caregivers to link both to their utilization data and to the patient's caregiver data. We also sought permission from the patients. So that's an example of a specific real-world study with a few separate components that's utilizing these larger, what we call the population data sets. In some instances, linking different population data sets. In other instances, linking all of that information to individual personal information that we have collected from those individuals. And all of them, our report is due to the ministry now, May 15 of 2016. Where will ultimately be used as input into this council's decision on whether or not they will continue coverage of these drugs in this province. They might discontinue. They could continue for anyone a doctor fills out a special authority form, or it may turn out that it'll be recommended that a particular subgroup of individuals should be covered. The randomized controlled trials of these studies show a small statistically significant effect of these drugs. What that means is that some people benefit, but it's not everyone. It's clearly less than everyone, less than half. And the statistical significance is so small that a lot of clinicians say it's not clinically significant difference. So there's a lot of current controversy around the drugs, and that's why we've been asked to do these studies. And there you have it. Thank you.
You can be Don, I'll be Phil.
Okay.
Great, thank you very much. Those are four very interesting presentations that really covered the ground on both the issues around creating these large-scale data sets and the architecture and some of the privacy considerations involved and who has access and how, and then some very interesting suggestions about some of the potential uses of those large-scale data sets, and really trying to figure out what it means, how it can all translate into meaningful outcomes for patients. And I presume too that they have to be meaningful outcomes that we can afford. So that certainly puts an extra bit of top spin on the whole discussion. So just some feedback. Thank you. So with the conclusion of our panelist presentations then, we'd like to open up the discussion. We have a couple of microphones for people to use if you want to ask a question, a general question or a specific question of any of the panelists. So here's what.
Okay, thank you. I have a question that I'd really appreciate if all of you could take a stab at answering it. It relates to what David just mentioned about the impact on the outcomes for individual patients or members of the public. So we've heard tonight about the power that can be harnessed by looking at data, population data, in terms of influencing policy. So I guess the question for Neena and Michael would be to look at how does that translate? Can you provide maybe an example of how that translates into the health and well-being of an individual, of our neighbors in the community, et cetera? And for Ken, for example, a patient coming in for a clinical encounter for mental health at the hospital, what that looks like now versus what that could look like with the completion of the research and a realization of a new way of using the electronic health record. And for Scott, looking at an individual, say a 55-year-old, under the care of a physician that starts to have the ability to interact with the electronic health record, to input data and then to see data, as well as having others involved in their care see data. So if you could bring down now that level of the research and all of this work to the level of an individual. Okay.
That's on. Well, I mean, I guess certainly in my example, I mean, we're giving a report directly to the ministry and to the group that's going to make a decision on coverage. So it's going to affect individuals who would be eligible for coverage. I mean, it seems to me that in my example, the implication is very clear. I mean, what isn't clear about it is how much weight the particular decision-making committee is going to put on our report. And I think I said the report was due May 15, 2016. It's May 15, 2015. It's in a couple of months. It's due. So, and it's true, you hear so much talk about evidence-based research. Research is always only one input into health and healthcare decision makers. So you can't have control over what the outcome is going to be in that sense. But the ADTI is an example, certainly, where we will have input, but we can't tell you what influence that input is going to have.
So maybe I'll go next because you put Neena and I together. So I just want to say a couple of comments about your question, and I would certainly appreciate it, Cindy. Thank you very much. I just want to begin, though, by saying already we're into the healthcare system and talking about patients, and I think one of the things we have to keep our eye on is that these kinds of approaches to analysis can help us understand other factors that aren't inside the healthcare system and that open up important questions across a broad range of social policy issues and so forth that actually may well improve health outcomes without turning people into patients. Having said that, I can think of a couple of examples that I'm happy to share with the group. So the first is, we know right now there's an enormous court challenge being thought through about the role of private medicine and private clinics being led by Brian Day. We know that from our analyses of WorkSafe data that people who are injured, particularly knee injuries at work, actually have a faster return time to work if they're seen in public hospitals and not in private clinics. Now that's kind of an interesting piece of data that should be part of our public discussion about the role of these sorts of things. I'll give you another example. Sitting in the back of the room is one of my PhD students, Sandra Markey. She and I are working on using these data sources, try to understand the impact of perpetual caregiving. Neena talked about caregiving in the context of Alzheimer's. We're looking at families in which there's a child with a significant disability and trying to compare health outcomes not only of those children, but of everybody in that family cluster, compared to families where there's not a presence of a significant disability in children, to see whether or not those siblings are affected through, for example, their educational attainment scores or frequency of morbidity or episodes of morbidity as indicated through these larger data sources. If they get sicker more frequently, less frequently, or about the same rate as other families. Do those episodes last longer, shorter, or about the same as other families? To help us understand, there's been never a population-based study of disability in this province that doesn't rely on individual reported information. And so this is going to be the first big population study of its kind. What we're trying to figure out is if we can detect some of those stress pathways that Scott referred to, playing out in the context of a perpetual need to meet people's daily needs, not only as they present in special cases, but all the other people involved too. What happens there? We have no information about that right now, and I think that would be a really important contribution to our understanding of the way in which social policy and how we respond to disability can actually be managed by some of these things. One last point I'll make is that it also opens up the opportunity to think about caregiving, not about disability, not about aging, not about any other particular disease, but a collection of activities that we know as caregiving and their impact on human, on health and well-being. So I think those are the kinds of things that we can learn quite directly. Some of them relate to clinical cases in management, others relate to a broad spectrum of public interventions and social policies that should be analyzed, that should be reflected upon to help us maximize the investments we make in human health and well-being.
Okay, well, I'll answer by putting myself and putting Scott on the spot. Okay, so let's take the example of the cohort of people in their early teens who were starting to display some of the signs and symptoms of major psychiatric illness like schizophrenia. We have reason to believe, so we already know that the diagnostic entity schizophrenia is not terribly helpful because that group of people are, so heterogeneous in the trajectories that they track over the course of time. Some of them end up with comorbid substance use disorders, living on the streets, losing on average 22 years of their life associated with excess medical morbidity and healthcare costs. Others don't. So just the diagnostic entity in and of itself is not terribly helpful, and we would like to be able to use some of the admittedly dirty Dust Bowl empirical kind of data mining tools to plow through our data and see if there's other ways of identifying naturally occurring groups of people who are in fact differ according to the trajectories that they track. Okay, now I'm going to put Scott on the spot. So we have good reason to believe from the data so far that frontally mediated functions have a critical determining role on the long-term outcome for people with a severe psychiatric illness. We also know that getting good, robust measures of frontally mediated functions is notoriously difficult, and we would have good reason to believe that the best way to do that would be by employing repeat burst measurement designs, which are notoriously difficult to analyze unless you have people who are heavily fortified with a kind of analytical and statistical skills that are well represented in the Center on Aging at the University of Victoria. But if we want to implement these repeat burst measurement designs, it means you got to get something in the hands of Johnny out there who is 13 or 14 years old, so you probably need some kind of gamified sort of application, which then brings in Dr. Jens Weber and associates to help us develop these portal-based platforms and other people to develop applications that Johnny, in fact, would want to use repeatedly. Scott Hofer and associates then analyzing the data coming in so that we can identify as early as possible who is going to turn to, who's going this way and heading toward the streets, and who is heading in some other direction. So I think that we're talking about, first of all, you can't do that kind of research unless you've got a partnership with a health service system that is engaging with Johnny and Associates. You can't do that kind of research unless you form an unholy cabal with people like Scott and Associates. And then you can't translate that information into practice unless you can roll the information back into I would say the clinical decision support and alert. You want to translate it back into the alerting functions in the electronic health record to raise the flag as early as possible and say you may have some problems. But I would also note that when you look at what determines what trajectory Johnny is going to track to, you're probably going to find that it has a lot more. It has to do with a lot more things than friendly mediated functions. You'll probably find that it also has a fair amount to do with the socioeconomic status of the parents because of the downward socioeconomic mobility associated with major psychiatric illness, and if there's some other factors that can mitigate it, that's probably going to help a lot. So we already know that we're only going to have an incomplete picture if we rely exclusively on the health data. So we need these sort of high technology repeat burst measurement designs with the statistics associated with it. We need the capacity to build it into the electronic health record. We need some of that other information on the non-medical determinants of health, and collectively we can piece together a picture that I think can enable us to do a better job than we're doing now.
Unholy cabal. Right. I'm going to take Cindy's spot. She put me on first.
I'm starting to feel uncomfortable here.
No, it is so much fun to work with Ken, I say. Cindy, I would just, a quick answer to your question. Behavior change is very hard, and sustaining behavior change is even harder. I have some colleagues in Germany who are running a clinical trial on rehabilitation following cardiac surgery. So it's a lifestyle intervention. You want to get people more active, more physical, more regular basis, also change their diet. So there, in Germany, they have a 1 or 2 month where they have a person who's meeting with them and doing this, but after that, it's done. So this is a web-based intervention to try to sustain this. So that's currently ongoing. It's that kind of thing that I think we can have an impact on. There are certain people who really like this idea of quantified self, who are wanting to measure themselves and measure their performances, physical, cognitive, whatever, and to really identify, what is it that I can do that will really optimize my behavior. And so they basically use this to put themselves through their own tests. In a way, that's what our research has always been about. It's been about trying to identify what a person is doing, selecting, deciding on, as well as what's happening to them in terms of external kinds of influences that matters, that makes a difference in their functioning, however you want to measure that. And so that's what our research is, and now people are kind of being able to do this themselves with all the technology that's available, how easy it is to measure your activity, your balance, your gait, your cognitive performance. All of that stuff's out there now. The trick here is to feed it back in such a way to everyone so that they can use it, and they can, basically it produces a within-person cause, that I did this and this is what happened. And to show that regularity and the fact that hopefully it will kind of build in, and that information will help reinforce behavior and sustain behavior change in a more positive way towards better outcomes. But that's the idea. That's the real challenge that we're facing. I think it's a very exciting thing to work towards. So thanks for that. And the analytics and everything else, yeah, it's just, that's where we're at. We're really trying to detect these patterns and changes and risk profiles to be able to act on them.
Great, thanks. Other questions or comments to the panel? Yeah. You want to wait till the microphone comes down, please?
It's an easy question.
That last one was purportedly an easy question too. So.
Yeah. I recently read that as much data is now being created every 2 days as it was created from the beginning of human civilization to the year 2003. So size matters. So what size of data will we sort of looking for here in a population health data, including the the VHR data on electronic health data is being collected? What sort of if the size is huge, do we have the methodologies and statistical techniques? Our statistical techniques are old. It's not all normally distributed, and the parametric statistic may not work on some of these data sets. So I just want to hear your comments that whether we should concentrate on methodology or should we concentrate on just fishing the data. But you said you won't allow us to fish the data, Michael.
Okay, well, I'm going to fall for that one, hook, line, and sinker. Currently, of course, you have to think about the history of this. 10 years ago, there was very much a data chill in this province. And it was almost impossible to get the research enterprise to work by trying to rely on secondary sources from government. The reasons for that are weird, and we don't need to necessarily document them here. The point is that's what would happen. That is what had happened. So when we first put together the application for what became POP data, we had to deal within those kinds of confines. And it was very clear that we could only ask a single question or a very tightly circumscribed set of questions, and data would only be released to explore those questions and preclude then opportunities for other kinds of hypothesis-generating kinds of activities. I'm happy to say that we are in a slightly different place now, where it's not nirvana. We have a lot of work to do. But there's being a relaxation of that, partly stimulated by, I mentioned the spore earlier. And one of the things that happened in the spore process in this province is there was a wide consultation with the research community. And the biggest message that came out was we need greater access to data. That was the highest priority listed, such that access to data and questions about data systems will likely account for approaching half of the total budget put into the SPORE initiative. And part of that negotiation was also with government to ensure that we would get access to those data and that we could make them available. And that if we are talking about patient-oriented research and involving patients, they too need to understand these processes and think about them. And if we're thinking about trying to improve the system, given the new techniques that have emerged around data mining and so forth, why can't we use them? So that last slide that you saw on my slide deck indicates where I think we're going, which will be actually greater opportunities. I don't think the issue about amounts of data are really rate limiting for us right now because computing technology is so incredible. I think the issues that you talk about with respect to methodology are big challenges for us. At the same time, we have new emerging techniques such as those that Scott is using, for example, that really do help us to get a handle on a longitudinal data set. Moreover, part of the reason why I think the mission of training within POP data is so important is to help to inspire the curiosity of emerging investigators to think about ways in which they might use these data. And I'm talking about people who are digital natives, who understand the world in a very different way from the way that I understand the world. I tell people, you will find me on phone book. So I think, there are new techniques that I think are emerging, and we will never have perfect methods. I think that's a holy grail that we will keep pursuing. But we have opportunities to improve our methods and understand things in ways in which will allow us to catch up with the opportunities that reside in the data sources that we have available to us.
I would just add to that and just say, you've heard some excellent examples of how this data is vitally important now and what it can tell us now. I suppose my bias is more towards natural history. I want to know what kind of changes, what a person's doing that matters for these health outcomes that are now in the health records. And so I guess that's kind of my bias. I'm towards adding in some structure to data collection in a more regular way that's going to be in parallel to the kinds of health records and health usage where we're going to learn about a lot of these changes, biological, behavioral, sociodemographic, all these changes that are occurring that are going to feed in and help us really understand that the processes and the factors that are important for many of these health outcomes.
Great. Well, let me use Chair's prerogative to ask a quick question and just go down the panel quickly while other people are thinking about other questions. So a number of you, yeah, thanks, Sally. A number of you have actually all said something about the unique concoction of things that we have here at the University of Victoria and the partnership with Island Health and access to data, POP data, proximity to the ministry, our research centers here. Is that a special concoction in your opinion that allows us to do something that other groups across the country are going to struggle to do? Do we have access to a unique collaboratorium here to work on these exciting problems, or are we just pretty much like everybody else? So what are your thoughts about that?
Perhaps I'll go first because I've probably been around this area the longest on this panel. I think the efforts are laudatory. I think it's where we have to go, but we're actually not the first, and we're not the first in Canada. When I was in Manitoba, which I was before I was here, I came here in '92. In fact, there is a University of Manitoba Research Centre. It's been going for a long time now, and they've had access to population data and ongoing regularized contracts with the government to analyze it for questions of value. A colleague I worked very closely with in Manitoba, they were oriented towards aging, but at that time they were unique, large surveys of elderly adults in the province, primary data, extensive interviews, and we would link them to the POP data. I think what's a little bit different here, in Manitoba it's done on a provincial level. Here it's being done, the POP data is on a provincial level, but linkages with VIHA are on a regional level, and whether that'll evolve so each region does that in this province or it's brought together at a provincial level, I don't know. But I don't think that should detract from what's happening. And if, in fact, this province can, within the healthcare system, link in individual level data with the POP data and actually use it, and that's always the big trick. But if they can actually evolve this in some way for decision making within the system, it will be unique.
Great, thanks. Any other reflections?
Yeah.
We keep them brief. We've got one more question.
Okay.
So,
Agreed, there are a number of instances out there, but I think we've got something very special here in terms of they're very much a shared vision across Island Health and Island Health clinicians, UVic researchers. Cerner Corporation is a big player here because they're bringing software expertise and expertise about how to manage and how to make use of this. And they're very, very interested in the kinds of innovations that I think are being developed here. I think we also have a different emphasis, and that's towards the within person. I think that's really understood and shared, and I think we can do something quite innovative and quite rather quickly, and to have impacts on projects already. The one thing I found is a great deal of interest in by clinicians and clinician researchers at Island Health, and that kind of collaboration, the kinds of projects that are happening here are I think just top notch, and I think that's going to lead the way.
So I would agree with that, and I would add to it, I think Neena's point is exactly right. There are other players, and Manitoba Centre has for the longest time been kind of the leader in a certain way in the country. That doesn't mean that we can't be the leader in British Columbia, and it doesn't mean that we can't really be out in front of that lead at UVic. You think about the strategic advantages we have. We have a moated community, we have a relatively stable population, we can sort of track in ways that other regions in this province can't because of those fluid boundaries. Where does where does Vancouver Coastal end and Fraser Health begin? Those are really difficult things for systems to work with. We don't have that problem. We've got a willingness of partnership. We've got a fantastic leadership both at the university and at Island Health who sees the opportunities here and the importance of pursuing this. We have a mission to be engaged with our communities, and so all of this activity is completely resonant with that. And I think we've got a fantastic opportunity. I do believe that the conditions for this work have never been better in the 25 years that I've been living in this province and working in this area.
Okay, well, I'll put my nerd hat back on. So these comments are completely neutral and uninfluenced by where I happen to live and work. If you just want to do research and derive knowledge from information, then I would say the situation here is not unique. If you want to be able to complete the loop and translate it back to practice and then confirm and validate whether your ideas about what is the case are in fact correct, then I think we have quite a unique opportunity. Michael, you'll noted the word moded community. I've written down on my piece of paper here, so I don't need to repeat that. Within Island Health, we have a single platform that covers every service. Well, it doesn't. It's talking to GPs, but it covers the hospital and community-based services, large volumes of linked longitudinal data. It's a full-service health authority as well, so most people get most of what they need without leaving the island. But the other thing that I would note is that this is not just a scenario where where the health authority is turning to the researchers and say, "Hi, here's our data. Hope you like it." What we are doing is saying, work with us to configure the base, the tools that are being used to supply the base data in the first place. Help us configure the electronic health record in such a way that we're getting the information that we need both to optimize the delivery of care and to drive the knowledge agenda. And we are also talking about opening up the electronic health record so that the clinical decision support rules that lie at the heart of what makes the new electronic health record new can be modified by the knowledge that gets generated from the research community. So the opportunity for the research community to participate in the complete loop, including opening up the electronic health record on the basis of what the data requirements are and what the knowledge products are, that I think is unique.
Great, thanks. One question there, and then Martin will get you. So quick question, quick answers, because now we've got two questions.
Yes, two quick privacy questions. One related with data mining. It's my understanding that FIPA Section 35 allows researchers use of data for particular objectives. Data mining is not really a particular, like a specific objective. Funding also usually is related with specific research questions and whatnot, so it's not captured under that framework either. So administrators probably wouldn't be that forthcoming on approving release of data for phishing. So that's one, if you can comment on this question. And second, there is mention of opening of electronic health records and GPs. So I noticed in doctors' offices, they have their computers, they enter your clinical record there, and via software that they get from their respective health authorities. That information belongs to patient, doctor. Is that information somehow funneled to the health authority without any consent from the patient? I'm just curious.
So how about just you can answer this, and then we'll take the final question.
No, I would say that the patient coming from the GP's private office is not getting sent to the health authority, and the health authority. So the health authority does not have those data, and it would have no authority to disclose those data. The physicians are operating under a different piece of legislation as well. So I'm not seeing that as a concern. the challenge is to move the information in the other direction, to keep the the physician appraised of what's happening on the other side. There are privacy issues involved there as well.
If I may just, you're absolutely correct on the data mining side, and I think today we wouldn't be able to do it. I guess what I was trying to signal is that there may come a day when there are, and clearly this will not happen just overnight, and it won't just be suddenly everybody grab a fishing rod and jump into the data pool. It will be probably very controlled and around specific kinds of questions that we might find new ideas about by taking that kind of approach.
Okay. Thanks, Michael. Okay, last question of the evening.
In relation to the last question, Island Health has approximately 350, 375 acute care beds on the island. We have approximately 5,000 residential care beds. If you reframe that question, on the island, we have 750,000 patient beds, because everybody's a patient sometimes. And the question is, what's in it for the GPs, the family practitioners, to allow their data to be used for that population level studies? In other words, where's the incentive? Because we can unlock that on an individual GP by GP basis.
Okay, Michael.
Great question, Martin. Thank you. And I think the answer is it's going to be a slow process, but what we really need to recruit into it are the early adopters, those GPs who see some value in this because they really want to improve or to offer the highest level of care possible for their patients. And, you know, if we can just get a small cluster of them involved, then we can get the information we need. We don't need a census. We don't need everybody to participate. We just need strategic alliances with GPs' offices to feed some data to help us answer some really important questions that might be augmented by linking those data to a broader set of data sources to ask specific kinds of questions that would be helpful to everybody. Once we crack that nut, I think we will have more and more people wanting to participate, but we can all benefit from the knowledge created even if we don't have a census. If we have a small sample of 10% or so who offer up those information sources.
Move that information on. Can't I push that? Yeah, can't I push that way?
Well, there's another angle on it.
Yeah, Martin asked, how do we incentivize the physicians? The question is, how do you incentivize the patients?
I think that's where the answer is. I think we need to incentivize patients.
Great. Okay, Ken, you get the last word.
Okay, well, yeah, you can authorize the GP to disclose the information to the health service system, but the pipeline doesn't exist to get it there. So, so it just can't happen right now. Okay, yeah, Dr. Whale, you know, my impression is working and engaging with the GPs around a project to enable to expedite access to medical imaging procedures is that I'm not hearing GPs calling out for us to generate new knowledge products from our data and then inject that knowledge back into the GP's private practice. But what I am hearing clearly from the GPs is the use of technology, is the production of technology that is really, really simple to use, works, and enables them to perform the routine functions that they do in the context of delivering care over and over and over and over and over again, efficiently, quickly, reliably, and relieve them from the burden of having to keep track of whether all the stuff that's supposed to be happening is happening. So I think that is a good point of entry into a dialogue with GPs.
Great, thanks so much. So, as you know, IdeaFest is on for the rest of the week through to Saturday afternoon, and I certainly hope that you're able to go to many of the other fantastic events that are still on during this incredibly rich week during which we celebrate all the wonderful facets of UVic research. I'd like to thank Tara Tedesco, Sally Esches, and Brad Berry for all of their work in putting not only this evening's event together, but all of the other events through the week, and also a round of thanks for our panelists tonight. Thanks, everyone, and good night.